My favorite part of your PhD was actually at the early part, your acknowledgement. It's a note to your family. You said, I have to begin by thanking my amazing wife, Susan. I started out on this journey in 2014, extremely naive and not knowing what a period of research would have in store. What it entailed was 4 years of hard work, being on call virtually all the time, late nights, early mornings, highs, lows, missed or broken sleep, liver offers, and some days away from home. This thesis is as much for you as it is for them. The following is a conversation with Mr. Richard Laing. He's an upper gastrointestinal and hepatopancreatic biliary consultant surgeon working at the University Hospitals of North Midlands in Stoke. In his training, he took up a Wellcome Trust research position where his work has helped change practice in liver transplantation worldwide. Through his experiences and leadership positions, Mr. Laing is not afraid from using social media to support his colleagues and highlight changes needed for a better functioning NHS. Working alongside his consulting colleagues, he works in one of the largest general surgical units in the country, offering specialised care for patients across Staffordshire and the Mid Wales region. To support the channel, please like and subscribe and check out our sponsors in the description. And now, dear friends, this is us getting a second opinion from Mr. Richard Laing. Hello, Mr. Laing. It's very nice to have you today.
Thanks for having me.
So you are an upper GI surgeon based at Royal Stoke.
Yep.
We've had a few doctors on this podcast and talked about their experiences, but you are the first consultant surgeon. Okay. Could you talk about the feeling when you are in surgery and you've got someone's abdomen's open? What's going through your head? Is it nervousness, excitement, challenges? Could you talk about that so people can understand?
Absolutely. Well, I've been a consultant for 2 years now, and I think the overwhelming sense I get when I'm operating is, first of all, that's what we love doing as surgeons. That's why we do the job. Okay, we want to get in there and we want to try and make people better by doing an operation which sometimes is very complex, sometimes is high risk, especially in hepatobiliary and pancreatic surgery, which is what I do in my day-to-day work. But it's a real privilege to be able to do it, I think, and that's always at the forefront of my mind. You build up a rapport with the patient. They genuinely put their life in your hands, and really that's what the training is for, to get you in a position where you feel comfortable doing that. It's exciting, it's nerve-wracking, it gets the adrenaline pumping at times as well, depending on what case you're doing. There can be surprises along the way. No two patients are the same, and so there's a great camaraderie in theatre. You're working as part of a team with the scrub team and the anaesthetist and the ODPs and ODAs, and of course you've got trainees with you, so you're imparting knowledge, you're trying to train them as well, and it's absolutely fantastic to see progression in trainees and see them coming on over the period of time they're with you. So there's so many different aspects to it, and I think that's why I fell in love with it at the time, in the early part of my career, and it's just got everything that I really enjoy, which is problem solving, working with my hands, doing something that is a lot of medical treatment that sometimes goes on is a long protracted treatment, but with surgery you see the effects there and then. You can have a patient who's on massive amounts of medication to support their blood pressure because they're very unwell with sepsis, and within 15-20 minutes you see that coming down and they're making improvements, and they wake up at the end of the operation, and then also seeing them on the ward afterwards, speaking to their families, a lot of the time, hopefully the majority of the time, they're very grateful, and there's a real sense of reward there. So it's multifactorial, I think, is why I love what I do. Yeah.
Thank you for sharing that. Okay. I think I asked, so most listeners would actually be medical trainees, and myself, I'm interested in surgery, and I guess I can somewhat understand the feeling when I'm on the wards dealing with a medical complication. But let's say you're in theatre and you have your good camaraderie team there, You've got your SHO, maybe even registrar, but then it comes to you as the consultant to maybe take the lead on a challenging aspect of, let's say, a Whipple procedure or procedure in the abdomen. What's going through your mind then, whether that's stress, nervousness, or actually calmness? How do you deal with all those feelings and emotions?
I tend, when I enter a stressful situation, I tend to, if anything, become a bit more quiet. I still communicate with people around me, but I've never been a shouter. I've worked with shouters, but I don't find it really helps either myself or the people around me in those sorts of situations. I think what you do is you fall back on experience and very simple measures which help get you out of a certain situation. And it's all about regaining control as quickly as possible and giving people around you the ability to sort of take a breath, and yourself to take a breath as well. I mean, if you look at what we do in major pancreatic resections, it's mainly bleeding where the issues arise, and
the stressful situations.
And venous bleeding, either from SMV or portal vein or splenic vein, and it can be really challenging to get on top of that. But again, you have to just try and stay as calm as possible, because you do have to be able to, think on your feet and do sometimes quite technical procedures in order to regain control. And if you are panicking or you're getting angry and shouting at people and blaming people, it just doesn't help. I mean, sometimes that's just the way people manage these situations. But as you'll be aware, there's a huge amount in terms of non-technical skills in theatre, not just the operation you're doing, but human factors and getting the best out of the people that you're with. And I just find that the way I do things is I tend to quieten down a little bit. I might not speak very much. I'll just be giving very, very sort of specific instructions to the people I'm with. I'll ask for sort of theatres to quieten down. If there's a lot of background noise or if there's music playing, I'll get them to turn it off. And when everything's under control, we just sort of everyone takes a breath and steps back, and then we carry on. And it is, it's also the reason one of the main reasons I chose to work where I'm working is my colleagues and the ability to call on colleagues who I trust and who are willing to support me when I need it. And I've only been a consultant for 2 years, but the surgery that we do is high risk, and even more experienced colleagues will call on me for support. And that's hugely important. And generally, I'm operating, if I'm doing a resection, with a registrar, maybe just one assistant, and sometimes it just takes an extra pair of hands to get things under control. But it's just about, again, as I say, fall back on experience, previous problems that you've encountered. I mean, surgery is a lot about common sense. Sometimes you have to just not quite make it up as you go along, but you'll come across a problem that you might not have been anticipating, and when you've been training for 15 years, you do build up a sort of library of techniques to get you out of trouble when you need it.
I guess, what advice do you have for people interested in surgery, medical students, junior doctors who maybe still find surgery quite intimidating, being in that place with a consultant and registrar, maybe lacking that knowledge, whether that's surgical knowledge or actually those human factors that you talk about. What advice do you have for actually now developing that calmness in stressful scenarios?
Well, there's a lot of information out there on how to deal with situations like this and the theory behind it. I've been lucky as I've come through my training that I think there's been an increased awareness about non-technical skills, human factors, and how environments can affect patient outcome. There's a very there's a fantastic initiative which came out of the sort of emergency medicine environment in Coventry called Civility Saves Lives.
Okay.
And there's clear evidence now that incivility negatively impacts patient outcomes. Okay. And in order to get the best out of your team, there's lots of examples where people have felt they've not been able to speak up in certain situations, and that has led to, in some cases, unfortunately, patients dying. So I like to think that the field of surgery is changing. There have obviously been very high-profile publications in recent months. Not even that long ago, about ongoing harassment in the field of surgery, bullying, sexual harassment, and it really pains me that is still going on. And there's a responsibility within the surgical community to stamp that out and call it out when it happens, and if you see it happening. And I understand the history behind why. The surgical field, it can be daunting. Only yesterday there was a Twitter discussion about a malignant American surgical training program, and how it was very toxic, and there were surgeons still supporting that as an environment,
Really?
Because they claimed that it generated strong surgeons,
robust
people. And I find it fascinating that still exists, that mentality, but it does. But I think it is changing. I think as my colleagues come through, my peers come through the training program, who've experienced those sorts of environments and worked with surgeons like that, who are undoubtedly talented. There's no doubt that they're not talented individuals. Some of the most talented surgeons that there have been, but they worked the way they did because of the environments they worked in and what they experienced, and they felt that was necessary to continue in the field they were working in. And there are plenty of examples of individuals where it's not necessary. And so I would encourage medical students, junior doctors, to seek out opportunities to get into theatre, to try and experience a variety of different surgical specialties. It's not just the operating, it's the clinics, it's the way we manage patients on the ward, it's the acute take as well, and the emergency take. So it's really important, as I've told medical students who've been with me, to experience the range of things that we do as surgeons, because the operating is actually, very important part of the job, but it's actually the smallest part of the job in reality in terms of our job plans of what we actually do on a week-to-week basis. It's about patient management. It's about knowing who not to operate on, as well as when to operate. Sometimes that can be the most challenging part of the job. And as I say to everyone who I am fortunate enough to kind of train and teach, you've got to find something in life that you're passionate about. So surgery is not for everybody, and that's absolutely fine. We shouldn't set out to turn everybody into surgeons, because some people just won't enjoy it, and that's absolutely fine. But equally, I would encourage people, if they do find it interesting, to seek out opportunities and to try and nurture that passion, because we have long careers ahead of us, hopefully. And you've got to love what you do every day in order to do it for the next 30 or 40 years. So picking an easy option, or in inverted commas, an easy option in terms of length of training, competition ratios, and to a degree quality of life, although I'm sure we'll come on to quality of life in surgery, is obviously important, but you've got to want to get up in the morning, and you've got to want to go to work, and you've got to want to enjoy what you do. And the easier route is not always the right thing to do if you're going to find it mundane, or really struggle to get going, and be passionate about it. So it's just about getting into theatre. And everyone's, you've got extroverts and introverts, and everyone's going to be in a different position, but don't be worried to go and seek out opportunities, because actually as surgeons, the vast majority of us love it when people come in and want to learn more about anatomy or see some operations and actually demonstrate some interest. So don't be worried about the fact that you're going to get grilled or shouted at, or I hope that is a fading experience for many.
I didn't expect this conversation to go in this direction, but I attended a conference 2-3 months ago in Sheffield as an orthoplastics student conference, but they had a orthopedic spinal surgeon, and he talked about those human factors in surgery, and he said they're developing that idea, and was talking about recent articles and saying, yes, that team cohesion in theatre, or responding to those moments where they're most stressful, and actually if you improve those factors, that can improve patient outcome. Like I was aware of it, that in theatre you get very stressful situations, or let's say critical points where maybe senior input is required there, but if the team is not working as well or in cohesion, he drew this diagram where he said a surgeon is relatively comfortable, whether that's opening up the abdomen and preparing it, but then let's say the critical point of, let's say, removing your cancer, that's the most stressful, whereas the anesthesiologist will be calm, will be very stressful at the very beginning, then calm throughout theatre, and then very stressed at the end when waking up the patient. And he said from knowing when at points different members of the team are most stressed, then you could probably lean for someone else to take a leading role. But that idea is still developing. About how best to actually work through that. Of course, you've got your own personal techniques, and maybe the anesthesiologist has their own, and trainees have their own. If that was formalized, that would be fascinating if that truly led to better patient outcomes.
Yeah, I mean, you as the primary operating surgeon, it doesn't matter what you're doing in terms of whether it's a lap chole or whether it's a bigger resection. You can get tunnel vision, and you really have to try and be aware of what's going on around you as well. At the end with the anaesthetist, you need to be kind of responding to any issues up there, any concerns that they may have. but equally, if you look at bile duct injuries, for example, the number of bile duct injuries that could potentially be averted if the assistant felt able to actually put their hand up and say, can I just ask a question? Can I play devil's advocate here? Are you too low here? Are you sure that might not be this? Do you think that maybe in this situation we should maybe do this? Now, obviously, you're going to have some trainees who are very junior, who might not have seen a gallbladder before, but irrespective of seniority and experience, people can still have a feeling that something might not be right. And you can pick up on cues, and sometimes as the primary operating surgeon, you can carry on and you can be looking at this anatomy and convince yourself that what you're looking at, when actually that's not what you're looking at. And so I try and have a very open discussion with whoever I'm operating with at the beginning of a list, and say, look, if I'm doing something that you're not comfortable with, or you're thinking, why is he doing that? Why is he about to cut that? Just speak up. Don't wait until it's done and then go. I was going to say, exactly. Why are you cutting that big blue tube? So there should be a very open environment, freedom to speak up, freedom to question, and that's a very healthy environment to be in theatre. And I'll give you an example. I mean, I was a registrar at the liver unit. I was working with Paolo Moisen, who I said is so sadly no longer with us, and he was this behemoth of transplant surgery. And he was pretty scary. I had a very good relationship with Paolo over the years, but he could be very scary. And he liked to swear in Italian a lot, and I would just convince myself he was telling me,
So you knew Italian swear words.
I would just convince myself he was just saying I was doing a really good job in Italian, shouting it. But, we were doing a particularly stressful transplant. Paolo always used to do what's called a blood flush. So he would he'd put the donor in, and he would plumb in the back of the caver, and he'd leave part of the caver open, and then he would plumb in the portal vein, and he would flush the graft with blood. And then he would, close off the caver when he felt that he'd flushed enough out, because, of course, the preservation fluid is very high in potassium, and you don't want to flush that straight into the cardiovascular system. So he's doing this blood flush. Now, I was like the second or third assistant, so I was, I was peering over at the back. I was quite far away. And I was aware that the blood flush was still running, and because I think there was either a problem with the vein or the artery. He'd finished the vein, and I think he was starting the artery, and he was worried about the arterial anastomosis. So I was aware that the blood flush was still running, and there's a sucker behind the liver, and there's blood going, and I noticed that the anaesthetist is starting to get worried about the monitor.
Is the patient going tachycardic?
Yeah, tachycardic, blood pressure's coming down, and he's sort of saying, you guys okay? And yeah, we're fine, and I'm going, excuse me, can I just say? And I was just getting told to, mind my business and let him concentrate. And eventually, I just had to sort of shout, Paolo, the cave is still open, okay? And and he thanked me for sort of highlighting it, but had I not had as good a relationship with him and felt able to speak up, I'm sure it would have been identified at some point. But it is an example of how scenarios can develop in highly stressful situations, and you have to be able to be open to other people speaking and asking questions. I'm sure there are papers out there that quantify or estimate the number of clinical incidents or so-called never events that occur if people had felt willing and able to sort of speak up in these sorts of scenarios. I suspect it's pretty high.
That spinal surgeon who was talking, he explained the story. I may be butchering it, but have you seen that experiments where there's people playing with the ball, and then they get that gorilla to walk in the background, and then they ask people to watch the video, and most people can't. Yeah. They forget that there's a gorilla. Yeah. Not just walking in, but dancing.
I've seen that. Yeah.
And he said a few times in theatre, he'd be in theatre in a long operation, and then when he would eventually look up halfway through, he'd see that the whole team has changed, and he's got a new assistant. And when you're explaining tunnel vision, I think that as an aspect of it.
Absolutely, and even as the operating surgeon, you have to be able to speak up and say, guys, can we just maybe keep it down a little bit at this point in time? I'm coming up to a tricky moment. Generally speaking, your scrub team are absolutely superb, and will pick up on cues as well. And I'll sometimes see, my scrub nurse sort of, out the corner of my eye, telling someone to turn the music down a little bit, or tell people just to hush a little bit in the background while we get on top of something. So it is definitely a team effort. I mean, we couldn't do what we do as surgeons without a huge number of people around us. So
I wanted to move on to training in surgery. We did kind of touch on this. Literature just shows that trainees do face problems with burnout. They face daily stresses, and one aspect can be actually with the relationship with their seniors. And it's known that they have difficulty raising questions, feeling inferior, even at times seniors displaying dismissive or passive behavior. A topic that is talked about is there a toxic culture in surgical training? You've recently, a couple of years, you've been a consultant, and I've worked with you, I think, 1 week when I was on upper GI, and I really enjoyed working with you. So from your experiences, or from what do you feel? Do you feel there is a toxic culture in surgical training?
I wouldn't say I experienced a toxic culture.
Okay.
Really at any point in my training. But that's not to say there isn't one.
Yeah.
Okay. just because I haven't experienced it doesn't mean that others haven't. I know people who have.
Yeah.
Okay. And I know people who are very close to me who've experienced toxic cultures. Me personally, I experienced at times a challenging environment and a very stressful and tiring training program at times. There's no doubt about it. But then I chose a specialty which is known to be associated with that sort of environment. And I certainly worked with some, at times, somewhat challenging characters.
Yeah.
But I suspect I knew how to manage those relationships. But there's no doubt that toxicity exists and is happening on a day-to-day basis, even still. I suspect it's better than it was. I think the people who trained me, I think, certainly trained in a far more challenging environment when it comes to the individuals that they were working for.
Yes.
But I don't think there's ever necessarily been as challenging a time to be a junior doctor, and that's not because we're not. My seniors, the people I trained with, were working 120-hour weeks.
Yes.
Okay, but they weren't necessarily seeing 40 patients on SAU in 12 hours. Okay, and they weren't necessarily having to deal with the challenges of that surround you nowadays in big hospital trusts, and they had a surgical firm which was like a family, and yes, it was hard. Yes, they got a pasting at times, but they probably felt also like it was worth it in a way, because they felt inclusive within this surgical family. And it's just a very different era. There's no doubt about it. There are so many other factors around at the moment. Not just junior doctor strikes, but all the other discussions that are going on in terms of the profession as a whole, and training programs and bottlenecks, and so all these things contribute to the overall experience of trainees. And so just because they're not doing a 1 and 2 on call doesn't mean that they're not finding it difficult. So, for me to sit here and say, I didn't necessarily experience malignancy or toxicity, is not to say that it's not happening at the moment.
Or improvements are still yet to be done.
There's definitely improvements still to be had. There's no doubt about it on a whole host of different levels. As individuals, all you can do is, I suppose, behave as you would expect others to behave for you, and try and call out toxic behaviour if and when you see it. And tell those individuals that it's no longer acceptable to behave like that. My training through the West Midlands, I had a very rich experience in a whole host of different hospitals. But my time as a more senior registrar was definitely challenging, and it was challenging because the patients we're looking after are very complex, and a lot was expected of us, and if you add in the challenges of life, and the economical challenges, and everything that comes with modern day training, long commutes, and then it all adds to the stresses and strains of surgical training. So it's important to have mentors that you can speak to, who can advise you. I'm incredibly lucky with the family I've got, and my wife Susan, who without whom there was no way I would have got through my surgical training at all. And I found it just so helpful to have her guiding me through, and as well as colleagues who supported me and could advise me on the decisions I was making in terms of the rest of my surgical training. So
okay, yeah. I guess, do you have any advice for juniors then who are interested in surgery, are interested in particular subspecialty?
Mm-hmm.
They're aware of the challenging situation that surgery is, and they will meet challenging people. What advice do you have for them?
I think irrespective of what industry you work in, be it medicine, be it law, be it a private sector, you're always going to come up against challenging characters. You've got to just know how to deal with them, and I think you should feel able to call out behaviour which you feel is unacceptable, and just be very honest and say, actually, the way you spoke to me isn't acceptable. And it might have been acceptable at a point in time when you trained, but it's no longer acceptable. I think there are pathways out there to support you within the trusts that maybe previously didn't exist. Supervision, clinical and educational supervisors. Sometimes the problems with the educational supervisor, and then that's another tricky situation. But surgical tutors, freedom to speak up guardians. I think the piece of advice I would give surgical trainees is, it is just a job. As much as we love it, if something happened to me tomorrow, the operations would still get done.
Yes.
Okay. And the NHS is a big beast, and the wheel will, the world will continue to turn. And that's not to say you shouldn't try hard and want to be the best that you can be, but you need to put it into perspective, and it is just a job. And I think there are more important things out there, as an individual. And I love what I do. I love love getting up in the morning, going to work. I love operating. I love my patients. But it's really important not to sacrifice other things in your life. Because, as I say, I think you find that you are replaceable, and that goes for anybody, I suspect, in the NHS. And it's really important to make the most of everything you can in life. And I think you get more out of work if you've got other aspects to your life where you can go and have downtime. And I think I've learned that as I've gone later on in training, the importance of taking your annual leave.
Other interests,
absolutely, other interests, hobbies, spending time with family, spending time with friends, and just getting away from it, because it can be draining at times, and if you don't get away from it, that's when you start to resent it. I think, if you go away and you have a week and you come back refreshed, you're ready to go, and patients want a doctor or a surgeon who's refreshed and is enjoying their job, not with someone who's resentful and is burnt out. And as I say, there are so many factors at play nowadays in medicine that weren't there previously. And I do get a bit exasperated at times hearing retired doctors talking about how it was in their day, and I tend to just let it wash over me, because otherwise I'd get a little bit worked up. I
think the reason I wanted you here today is I knew this about you. I'm glad we talked about it longer, as in like how you live your life, because I feel I'm also like that in the sense I love, being a medic and being ambitious,
Yeah.
and I have an interest in plastic surgery and academia, but I love finishing on time, getting home, whether that's watching Netflix
and what's wrong with that?
or
Do you know what I
exactly,
mean?
or
What's
let's
wrong
say
with
doing these side hobbies like
Yeah.
the podcast. Like
Yeah.
I enjoy that. I've worked hard to become a medic, but then
Yeah.
I've got that freedom to do other things. And
Absolutely.
Yeah.
Life is
and
short.
there are
I mean,
medics, and that's fine.
I am regularly having conversations with patients who have very limited time left on the planet.
Yeah.
Okay. And not just people who've led very rich, full lives. And it's no easier to tell someone who's led a very long, full, rich life that they have a palliative diagnosis. Okay. But when you're sitting in front of someone in their 30s and you're giving them that news, especially with the pathology that I'm dealing with normally, you've got to just enjoy the limited time we have, and okay, there'll be some people who say, well, actually, all I enjoy is work. Okay, all I enjoy is writing papers and working in a lab and going. That's absolutely fine. You do that. Okay. Personally, I absolutely love what I do. I couldn't imagine doing anything else, really. I'd maybe like to be an oil broker for just maybe 6 months or something. One of my best friends is an oil broker, and did very well for himself, and has not long retired. But at the end of the day, you've got there's this concept of fulfillment in your life, okay, and your working life only forms a part of that. Okay,
Yes.
You've got to feel rewarded for what you do. You've got to feel financially rewarded for what you do, and you've got to have all these other aspects of your life in order to sort of be in balance. Okay, and for me, that includes lots of other things around my career. You've just got to prioritize yourself, prioritize your family, prioritize your friends. Because friendships are incredibly important as well, and just go and experience what there is out there, and get the balance right. Because very quickly, if you don't get the balance right, your work will suffer.
I want to come back to that. In terms of the surgical culture, I mentioned in a previous podcast, because I had a conversation with the final year medical education leader at Sheffield Medical School. He said, you are going to enter, when you work as a foundation doctor, dealing with challenging consultants and registrars. He was saying that he felt the culture would change when the new generation come in, because let's say consultants now, I'm generalizing, but consultants now, they act the way that you may feel are intimidating, because that's what their consultants were.
Yeah.
And then the future trainees are becoming more socially aware that actually you can still meet the intensity of what's required on the NHS, but still be in a friendly manner. So do you think that's actually how it will end up changing through generations?
Or we're not saying that you can't pull someone over and say, you missed this, or you didn't do this, and I asked you to do this, and you knew it was really important, or
even you spoke to me in a way that I didn't quite like.
Absolutely.
That's fine to do.
But you can still, as a consultant, voice your frustrations at a situation that shouldn't have happened. It doesn't mean that you're malignant or toxic, okay, but humiliating people. If I'm pissed off that someone's done something, I don't say it in front of a group of people. I'll pull that person to one side in a quiet moment, or I'll say, do you mind if we just have a quick chat at the end? Fine. And I'll say, look, yesterday I asked you to do this, it's not been done, this has happened, try and find out whether there was an issue, and we just have a grown-up conversation, okay? But it's the other stuff that historically would happen, ritual humiliation in a handover meeting, telling people that they're just shit because that's just the way we do it here. That doesn't help anyone. It doesn't make someone a better surgeon. There's ways and means of doing it where you can actually have some reflection and some learning points, and so it's not necessary. It's just not necessary. So, and as a trainer and as an educational supervisor, I want to hear about that if that's happening, And I've had F1s coming to me in the past 12 months, sitting down and having a coffee in the office and saying, I just need to highlight that this has been said to me, or I don't like the way this is becoming a regular occurrence. And I'll go and I'll speak to the registrar and I'll tell them it's unacceptable. So, some people need to have some more insight into the way they present themselves and behave, because they may actually not think that they're necessarily being a bully. And very quickly I'll try and demonstrate that they need to have a real think about the way they're behaving, and we work through it, and generally speaking the vast majority of people reflect on what they've done and apologize, and it doesn't happen again. So I think you're right. I think things will hopefully continue to change, but the profession attracts people who are potentially sort of quite bombastic and outspoken and loud and in some cases arrogant. But even then, if that's their go-to, normal personality, then hopefully as time goes by, they will start to learn that actually that's not the way to behave. And hopefully, for example, the ARCP process and appraisal process becomes more transparent and less aggressive, because I have been sat in a few aggressive ARCPs in my time on the receiving end, and it's just not necessary. We're all adults, I'd sit in these ARCPs as someone in my late 30s with a wife and 2 children and a mortgage and all the other stuff that life comes at you with. And I've got friends who are CEOs of, private equity firms, and, someone who set up Innocent Drinks, and, kids I went to school with who are now at my level and running multi-million-pound industries. And I'm sitting there like being made to feel like a school kid. It's just not necessary. And you can see why, you can see why trainees start to get a bit frustrated.
Exactly.
And I always promised myself when I got to the other side, I wouldn't become one of those individuals, and I would be a bit more open to, the other potential stresses and strains that life can throw at you that may be impacting, your work, and also understanding the stresses of your, work life, and how adverse patient outcomes can affect you as a trainee, and how a set of busy on calls when you've got all these other deadlines and can affect you as well. And it's been an interesting run.
We can talk about your interesting life experiences when we talk about your PhD work, because it is 381 pages. I've not read all 381. I'm going to admit that. I'm not going to admit that. But it was a really fascinating read. And I would encourage people listening today to read as much of it as possible, all the publications from there.
That's very kind of you. Thank you.
No worries. But so we'll talk about your work, which was to do with human liver transplantation using marginal or discarded allografts. Could we first talk about, could you set the scene then for liver transplantation before your work?
Yeah.
Also, how did you get into it as well? I feel this is really novel work.
So,
this is in a PhD project. Like, you weren't even a long-term academic.
So I had no aspiration to become an academic surgeon. Okay. I knew I wanted to do HPB surgery. And I also knew that in the West Midlands, a lot of people who want to do HPB would rotate through the liver unit in Birmingham and end up doing a higher degree. Because when you come to the end, the competition is such that the vast majority of people have done either an MD or a PhD, and so I decided early on that I would undertake a period of out-of-program research, and I did so about a year and a half into my registrar training.
So in ST4?
ST4, yeah,
ST4.
halfway through ST4. Okay. So when I came out of program, I the research that I came out of program to do was actually a mouse model of alcoholic hepatitis. Very, very exciting.
Okay.
And by the time I got out of program, the research field had changed, and that particular model was no longer really that valid. And my supervisor is an incredible physician academic called Philip Newsome, who's recently gone to King's, I think, from Birmingham.
Okay.
He's a hepatologist, and he said to me, "Look, Rich, why don't you go and speak to Simon Afford next door, who's an immunologist, and he's doing something with a machine that you might find interesting with some of the surgeons. It might be more your bag." I think he could tell I didn't like mice. So I went and spoke to Simon, and Simon said, "Yeah, we're starting to do some work with these perfusion devices, and there's a machine we've got called the Liver Assist, which is from Groningen in the Netherlands, and basically you take a liver and you connect it up to the device, and it pumps round oxygenated blood at the body's normal temperature and at physiological pressures."
Yes.
And we're just sort of getting to grips with the machines, but they're looking to extend the preservation time. And there's another machine called the Organox, which is based out of Oxford, developed by one of the HPB surgeons there, Peter Friend, and he's also does renal transplant and things. So Peter Friend had developed this other all singing, all dancing machine, which we didn't yet have our hands on.
Mm-hmm.
And so what we were doing was we were getting livers that had been donated to us for research purposes from NHSBT. Okay. So the other thing that was going on in the background was that Phil Newsome was Mr. Stem Cell. So he had a collaboration with a company called Athersys from Cleveland in the US.
Okay.
And he had these multipotent adult progenitor cells, which were sort of an off-the-shelf product. And, you could use these stem cells in theory in various liver diseases. So that was also going on in the background. So I started work with the machine perfusion group, which was basically, I was already doing, I'd come out to do a research fellowship for 3 years.
Mm-hmm.
As you'll be aware, there's a couple of different types of ways of obtaining a PhD. One is to get a fully funded all singing, all dancing project, which is already there, maybe by Cancer Research UK, and you've got a team around you. There's a project there, and you come out and you do the project, and you're done in 2.5 years. You write up in your last 6 months, and you're back in program.
Mm-hmm.
This was not that sort of project.
Yeah.
This was a research fellowship where you developed your own project and you developed a PhD around it. And these research fellowships are normally associated with an on-call commitment. So it's a university position, but you're kind of employed by the trust to fill a slot on a rota, which is not that palatable. And then they allow you to do some research alongside. So for me, it was looking after the liver wards on nights and doing weekend retrievals. Okay, so
every week,
2 and 3 weekends.
2 and 3 weekends.
Okay.
And then 4 or 5 days on the PhD.
Yeah. So you would try and work around it. Okay. So you would try and basically, you do your on calls, and you would be doing your PhD around that. Okay.
Mm-hmm.
But because I was doing a machine perfusion trial, what that looked like was basically being on call all the time for machine perfusion. Okay.
Yeah.
So, for nearly 4 years, I was kind of on call for discarded donor livers, along with another fellow, Barney Stevenson, who is now in Cambridge as a senior fellow in transplantation, and Joseph Attard and Yuri Botion. So there was 4 of us at various times. Okay, Barney left shortly after I started, and then Yuri was there, and Joseph. So there was a few of us around, but it would normally be a 2-man job. So it was demanding. It was really demanding, okay. And but also I hit it at a time when it was novel, and the whole field was developing at an incredible rate. Mm-hmm. Okay, mm-hmm. So what had already started before I'd got there was that Barney and Heinrich Mergenthal, who was the consultant transplant surgeon who had started the basic science research, they had perfused a number of discarded livers and had started to develop criteria that they felt demonstrated graft function on the device. And so we would check the blood gases of the perfusates. We would check the bile production, the flow, the resistances of the vessels, mm-hmm. And the flow rates that we were getting in the artery and the portal vein. So the criteria for liver function was developing, and Cambridge were doing theirs, and Newcastle were doing that. So there's a few other groups around that were sort of developing their own experiences. Mm-hmm. But what happened, 6 months or so after I joined, was we started to feel that we had enough experience to identify grafts that we thought would actually work and could be transplanted. And I remember speaking to Phil Newsome about my project when I started off, and I'd done a few perfusions, and physicians and surgeons are quite different yes. creatures. And I remember Phil saying to me, "So how do you know whether a liver's usable now?" And I said, "Well, the surgeons, they look at the donor information and the age of the donor and the comorbidities, and they look at the sort of warm ischemic time, if it was a DCD, or how long they've been on ITU, if it's a DBD. And then they look at how long it's been on ice, and then they look at the liver, and they look at it in the cold ice bath, and they look at the colour, and then they give it a squeeze."
It's like Grey's Anatomy.
And then they basically just decide on whether or not they think that it will work, or whether the patient will have a horrendous reperfusion injury, and whether or not they're well enough to be able to tolerate that. And I remember Phil's face. He was absolutely horrified. He was like, "You mean so they're basically just squeezing livers and deciding whether or not
this would work or not at the end of the day?"
Like, yeah, that's pretty much it. That's pretty much it. Because actually I had no experience of transplantation before coming out of program. Okay. I actually had to learn what a DCD and a DBD was. I was sort of just, HBB, never gone through a transplant unit before. So I was learning all this as well. So I was like, yeah, I think that's basically what they do for it. And I think this machine will hopefully give more objective evidence that the graft is working. So we got local permission from the local Novel Therapeutics Committee and Ethics Committee to be able to do a transplant in a patient with one of these livers that had been sort of rejected in inverted commas. I think this was a DBD that we did first. It was a brain dead donor, but there were certain aspects within the donor history that made it high risk. Okay, and so it had been rejected by another centre. Okay. And it had been offered to us for research
through
purposes.
These subjective protocols that we talked about. Yeah.
And the discard rate nationally was very high.
Is it? Okay.
But actually, it was also quite different between certain centres. So if you're a centre which does a high number of marginal donors, you've got all the teams around you who help get that patient through. You've got incredible anaesthetists who will ride the storm. Post reperfusion, you've got brilliant surgeons who will get that liver in really quickly to minimise the warm ischemic times. and not have to redo an anastomosis and various other things. You've got great ITUs who will get the patients through post-operatively. So your degree of risk goes up in terms of what you're willing to accept. Okay, if you're a centre that does 5 marginal donors a year, and you have a significant morbidity and mortality rate, you're going to be more risk averse. Okay.
Yes.
So NHSBT wanted ideally to kind of flatten that variability across the country, reduce organ discard rate, and it wanted to, as part of its 2024 vision, I think it was called, it wanted to give surgeons and physicians the tools to be more confident in what grafts they were going to use, and this machine just fitted the bill. Okay, so we got permission to trial a transplantation. We got the anaesthetist on board and the hepatologist on board and the intensivist on board, and sort of demonstrated our basic science data and they what we felt indicated a functioning graft, and we transplanted a patient, and the patient did well. And that really then gave us. We then went back and asked for more permission to do a small series.
Yes.
And we did 5 patients in total.
Yes.
From 6 discarded grafts. So one of the livers we didn't use, and we published that in American Journal of Transplantation. And then following on from that, there was a Wellcome Health Innovation Challenge Fund grant, which I don't think exists anymore in its current format, but it was a Wellcome Trust grant which we applied for, and we were successful in securing that grant, and it was about £2 million, which allowed us to do the Vital trial, which was the sort of the larger scale study in order to transplant 22 patients to demonstrate feasibility. And at the same time, one of my peers, David Nasrallah from Oxford, who's now a consultant transplant surgeon in Royal Free Hospital, he was running the COPE trial, which was with the OrganOx machine.
Okay.
And that was comparing preservation of the organ on the machine from the point of retrieval.
Yes.
And comparing it to cold storage. And they did a massive. I mean, David was always on the road in an ambulance with a liver. And how he achieved that was, a feat of human endeavour. But I mean, so that COPE trial was running as well. Big RCT, big European grant consortium for organ preservation Europe, and they demonstrated, significantly prolonged preservation times. Of up to 24 hours with this device, and a reduction in post-reperfusion syndrome, and so it was an amazing thing to be a part of. It was, as I say, incredibly demanding, and again without my wife, sort of, how the hell she supported me through.
Yes.
That alongside. Her own A&E training and raising 2 kids is beyond me, really. But we got there, and the patients did very well, and thankfully, this sort of theory of being able to demonstrate organ viability, because what the machine, what people slightly misunderstood, and it was probably the fault of the community in which we were in, was that there were people who claimed that the machines would make unusable livers usable, and that's not what they did. They highlighted livers that were
that are viable, that weren't viable. Yeah.
And there's lots of there's 2 different camps. There's the camp that believe in normothermic machine perfusion, and then there's the camp that believe that cold machine perfusion is better, because you get reduced reperfusion injury. And I'm not in the field any longer, so I'm unable to say what the current evidence is in terms of what's better. But there'll always be people who will, once they've backed a particular horse, will find it difficult to move their camp. But what I do know is that it gives people confidence in graft function. It improves logistics, and for certain livers, it certainly decreases post-reperfusion issues. And anaesthetists used to say that they felt it was a lot smoother in the post-reperfusion phase. For certain health economies, these machines are absolutely fantastic because you're transporting livers over massive distances, and physiologically it's much better for the graft to be on a device than be it a cold device or a warm device. As I say, people will find what works for them and works for their patients. But it enabled me to go and travel and see places I wouldn't have ordinarily seen, meet people, meet wonderful people within the field of transplantation. I was incredibly lucky to train with world-renowned surgeons in Birmingham, gave me lots of experience which I still utilise on a day-to-day basis. My vascular anastomoses and big resections and all my organ retrieval work and all these things which have been really invaluable. That was what it was.
Can I break down a few things that you had talked about? So just to give context for those listening, liver transplantation has been going on, partial lobe transplantations and even marginal. And then your work was to use discarded grafts and then allow them to be transplantable. And the reason that's the case is there is a problem with long waiting lists. Many patients with chronic liver disease waiting for liver transplantations. And you have these number of unused organs that are not being used, or many patients do pass away over 60 and by then you develop comorbidities of liver disease. But then it makes it functional for those patients to be used.
And donor quality is not improving. It's not with as a country. We are thankfully, health and safety is paramount. We thankfully don't have, as many young deaths as they do in other countries. But as a result, the donors that come through are comorbid generally. The livers are becoming increasingly fatty. And those fatty livers are at high risk of either delayed graft function or primary non-function where they don't work at all, or post-reperfusion injury. And so, all these, this is not a problem that was going to go away anytime soon. And there are increasing indications coming on board, like colorectal liver mets for liver transplantation, cholangiocarcinoma in certain circumstances. So. The number of indications are increasing. NAFLD is an ever-increasing pathology which we're dealing with on a day-to-day basis, and the nation isn't getting any fitter.
No.
So, both the causes of cirrhosis, the causes of liver cancer, they're all going up, and the number of donors are coming down, and the number of quality donors are coming down. So, efforts are being made globally to try and help sort that balance out. And in the UK, we don't have a big living donor program. Virtually all of our transplants are deceased donor now. It was. I'm very grateful for having been a part of a trial which has undoubtedly helped change practice.
Exactly. In terms of creating the vital criteria, because it's such novel work, how do you formally say this is the lactate level, or this is the amount of bile production we use? How do you formally say that?
I'd like to say it was really high tech, but it wasn't. I mean, it was a case of what would we expect a working liver to do once it's transplanted? Okay. So we want it to make nice bile. We want it to have low resistance throughout the liver tissue, and not have very high resistance, low flow rates through the artery and portal vein. So we picked physiological parameters, 150 mils a minute minimum for artery and 500 mils a minute minimum for portal vein. And we want to see metabolism of glucose. We want to see a liver that's metabolizing glucose. we felt that metabolism of lactate was probably the hard criteria for us, but there are other groups out there who are saying that's not important.
Okay.
So again, this is part of the rich tapestry of academia, and it's important, to have these different voices, even though they were wrong.
Yes, yes. Even though this all worked out exactly.
Well, there's still people out there who don't believe lactate metabolism is. I mean, it is a complex issue. I'm not saying that it's straightforward, but for us, we felt if a liver is chomping through lactate and bringing it down to normal levels within the perfusate within half an hour, an hour, then and we extended that out as we became more confident to 4 hours. Okay, but generally it was 2 hours. We looked for, and actually, if you put a good functioning graft on a machine, it would bring it down within 15 minutes.
Right.
Okay?
Right.
So, other things came into play, like insulin resistance of grafts in patients who'd had type 2 diabetes and were obese, and so there was lots of other possible factors at play. And even now, we've submitted a paper which looks at the metabolomic profile of these grafts from the Vital trial, and it's only now we've managed to get all of the analysis done, and that will come out and hopefully paint because what we really wanted to do was to have ideally a point of care test where you just dropped a bit of perfusate onto a sensor and it gave you a green light. Yes, you can use this. It's got the right metabolic profile, right proteomic profile.
Yes.
So, but this is for other people to take forward,
of course,
who are much more intelligent. I think I was fortunate to come out at a time when things were developing, and I'm very proud of what I managed to pull together for the thesis. And there were some other bits in there about stem cell therapy and Hemopure, which is this bovine oxygen carrier and things like that, fractionated hemoglobin.
Yes.
So there were some really interesting parts to it.
And the normothermic perfusion machine, did another team create it specifically for liver transplantations? Because that's not a new novel machine that's been used, from my understanding, in cardiothorac surgery for heart transplants.
So there are ECMO devices which kind of will help on a much larger scale take over heart and lungs and things like that. It's essentially a shrunken version of that. It's got an oxygenator. It's got a pump.
Mm-hmm.
And it's got some sensors, and it's got a basket for the liver, and that obviously there are much more complex issues at play, and in some of the other devices which are much more automated, there's a lot of sensors that are going on to change parameters here and there. But the concept of organ preservation and organ perfusion has been around for decades. It's just only recently where technologically they were able to achieve it to a consistent to a consistent degree. So again, there's various companies that have popped up. You've got Organ Assist from the Netherlands, which have made the liver assist, but they do one for kidneys. They do and Organox, I think, also has a kidney device now. There's a Transmedics, or a big American company. They have liver, lungs, the heart. They do DCD hearts as well. Where they have pacing wires sewn into the ventricles and will pump. I mean, it's amazing seeing these devices in action. And the human body's pretty amazing. That you can, the fact you can trick it into thinking that it's been connected into a body, and the organ just starts working is the sort of stuff a little bit from Frankenstein. But it is a beautiful thing to see when you have a liver that was ordinarily going to be discarded, that's come out of someone who has thankfully donated their body to organ donation, and the family have obviously gone through such trauma and have been willing to sort of give that consent that they are willing to for their relative to go through that, and then it then goes on to help another individual lead at times a long and happy life. It is a pretty amazing thing to be a part of. It really is, and that was the real draw to me for transplantation were the outcomes and this kind of ecosystem, if you like, of donors and recipients. And it was a very humbling experience to be a part of that. And I'll never forget my first organ retrieval. It was a really...
I was just going to ask, can you tell us about the day where the first human liver transplant was done for a discarded allograft? Can you tell us the night before, how you were feeling on the day?
I mean, it's a really nerve-wracking experience. And I used to worry all the time, because even if you transplant a usable graft, the patients can have adverse outcomes. You know, they can have a big reperfusion injury, they can have a delayed graft function, a primary non-function, and we didn't always have smooth outcomes. But yeah, I used to be really anxious at the time, not necessarily while the liver was on the machine, but I was apprehensive at times when I was asked whether or not a liver was meeting criteria, because that decision would sort of generally fall to the individual doing the perfusion. And obviously the facts were there so the consultant could see it, but sometimes they looked to you for reassurance that everything was running smoothly and there were no other issues on the gases that you could see. And then, of course, you'd hand the liver over to the surgeon at the time, and you would just hope that everything went smoothly, and thankfully the majority of the time it did. But again, it's just part of being this bigger team, isn't it? That we have in surgery, and it's so important. You know, it's a wonderful specialty to be involved with. And I think that's as well what drew me to surgery, was the fact that it is part of, you know, I always played team sports when I was a kid at university, and I didn't want to do something that was quite insular and lonely, if you like. So I wanted to be, you know, part of a wider MDT, because that's what brings me enjoyment. Yeah.
Okay. Not only I would recommend people reading your PhD, but also watching you on the BBC documentary At the Edge of Life, and your clip that was The Pioneers, a new kind of liver transplant. How was your experience actually being on TV then?
It was good fun. I mean, I got a lot of stick for it.
Really?
Yeah.
Why?
No, not like serious stick. But just lots of, you know, lots of messages from friends and things like that, you know. There was a particular clip which makes me cringe quite a bit, which is where I'm testing a blood gas, and I'm reading it, and I said, "Oh, the lactate's come down." I said that is textbook liver function. Right? And when I was at university, I used to live with this guy, Josh Jeffrey. Big shout out to Josh. And he's a good friend of mine, and we used to love watching Alan Partridge when we were at university. Probably too young for Alan Partridge, but Alan used to always say, you know, refer to something that went well as textbook. Yeah, it's absolutely textbook. And within about 5 minutes of that clip being shown, and I'm sitting there thinking, I can't believe I just said that. Why did I say that? Why did I sound like Alan Partridge? Within 5 minutes, Josh had sent me a spliced video, right, of me saying that little passage and then flicking straight to Alan Partridge saying that is absolutely textbook. So, you know, there was stuff like that. But it was a great thing to be a part of. It was great to shed light on the amazing work that researchers do.
Yeah.
Which is hidden all over the world, never mind in the UK. I felt like a bit of an imposter, really, for most of my 4 years in terms of surgical academia and working with really talented, incredibly intelligent basic scientists. Many of the basic scientists weren't worried about reminding me that I was just a surgeon. But the work they do, and a lot of it just goes unseen, and without them, I mean, they are just absolute heroes in terms of the work they do for under difficult circumstances with lack of funding, lack of acknowledgement, and really without the hundreds of thousands of basic scientists around the UK, we wouldn't be able to do what we do, and we wouldn't be able to give these fancy drugs, and that they've spent years and decades looking at a particular molecular pathway that they've targeted. And, you know, me connecting a liver to a machine, doing a bit of plumbing without oversimplifying it, you know, it pales into significance. But equally, what I really liked about the program was it shone a light on patients who are willing to take part in these trials, which aren't risk-free, you know.
Yeah.
I would have conversations with patients and I'd say, look, we've got this device. We believe it demonstrates liver function, but these livers have been discarded, okay? But actually, you know, the way I would say it to them is I'd say, we have surgeons here who would probably have used this graft if it had come to us first, okay? Because they are willing to, they are less risk averse.
Yeah. And
so you could be getting this graft without it being tested, but we're going to test it for you, okay? And as I say, we believe that this liver is, this machine demonstrates the ability for you know, objective liver function, and the vast majority were willing to. They were willing to get a liver any which way they could, and you know, they were absolutely delighted to be a part of a novel trial. But I would also be very honest with them and say, this is this is a trial. There is a risk that this liver won't work because we know that risk exists anyway, and this is a high risk graft. And in the worst case scenario, that means the liver won't function and you will be too sick to receive another liver. And that means you may not come through this. And the vast majority of patients were willing to take that risk. And
because of trust in surgeons or trust in doctors.
Yeah.
Right.
And just also this sense that they were part of something bigger and that they wanted to help others in the same position in the future. And again, that was just remarkable to me that people would be willing to put themselves in that position
or
and
trust in you.
Yeah, and Connie, who was in the in the series, she was amazing. And another woman who took part in the trial, who I'm still friends with on Facebook, and I see her celebrating her birthday every year. I mean, it is amazing that these people took part and got you know, fantastic outcomes. And I've just been lucky enough to be a part of their journey and give them access to grafts that they may not have, you know, otherwise received. Yeah. And but the whole process of being on TV was, again, quite strange, really. I mean, the way it came about was that the producers were doing the series, filming at the QE.
The whole season was
at the QE, and
yeah.
they were filming, you know, the really sexy stuff, you know, the max fac surgeons who were doing crazy,
I mean, transplant
stuff.
Surgery is pretty sexy.
Well, it's pretty sexy,
honest,
but you know, grafting bits of hip onto people's faces and you know,
yeah.
And they'd been filming, I think, down in the emergency department doing some trauma, and they were hanging around the theatre block, and they found me in a corner in theatre at 3 a.m, looking like I'd not had any sleep. I probably hadn't had any sleep for a couple of days. Because during the trial, what would happen is we'd get a liver offered 2 a.m. It would arrive, and so I'd come in, put it on the machine, and I'd babysit it, and then we'd transplant it, and then another one would be offered. So we'd just do, I think we did 2 or 3 back-to-back perfusions. So there were times where you were a bit sleep deprived. So they found me in this operating theatre, looking at this box. And this person came and said, "What are you doing?" And I said, "I lifted the lid." And I was like, "Oh, we've got a liver." They were like, "Right, let's just go back. What do you mean you've got a liver?" "Yeah, well, we've got this machine and it does this, and we're doing this trial." And they were like, "Wow, that's just unbelievable. Do you mind if I do some filming?" I was like, yeah, fine, yeah, whatever, yeah, no problem.
Did you know they were from the BBC?
I knew they were from the BBC, but I didn't think it would necessarily become anything, you know.
Okay.
So I take a blood gas and I go in, and he's going, just talk me through what you're doing. So I'm saying, okay, this is the lactate, and we're looking for markers of liver function and and that liver for some reason didn't get used. I think there was an arterial problem with it. I think there was an arterial anomaly or something that meant that we didn't use it. I think it was one of our first grafts that we had on the machine.
Okay.
And we didn't want to take any risks whatsoever. We didn't want to take any risks anyway, but certainly not on the first liver. So we decided not to use that one, but they took my number and I called them the next time. And actually, the liver that they followed was coming up from London.
It was,
and so there was a cameraman down there who got in the ambulance with the liver and came up the road, and it was like, so it was all a bit weird how it happened. But then, of course, all the other stuff comes. So the talking head part comes, where where they sort of interview you afterwards and they get you to do these sound bites.
So that's after you have done the surgery, Mr. Pereira.
That's after, that's after it happens. So, of course, what they want is they want real drama.
Yes, and I think you did very well, to be honest. I felt like you were dramatic, but professional. You could think of it being very cringe, and let's say out of character, because you're a very sensible person. Yeah. But I thought you did quite well.
They wanted real drama, and and so you would you'd answer a question. They'd give you a question.
Yeah.
How does it make you feel? You say, it's it's quite high risk, and then they'd stop it, and then they'd go, that was really good. Do you think you could just give it a bit more? What was the word they?
Pizzazz?
Verve. I think they wanted
verve.
A bit more verve, a bit more. They wanted more and more. So of course, in the end, you're like, really laying it on thick, and it comes across as it comes across. But it was a bit of fun, and my mum loved it.
She's watching it again and again.
Yeah.
Okay.
Yeah. So it was good.
But I guess, how did you feel in terms of the pressure of your machine being used? Also, it was novel work. What, Connie, the patient?
Yeah.
How many successful or how many discarded liver transplants
had we done before then?
Yeah.
She was quite early on in the process. I think she was number 4 or something.
Okay. And you were confident enough to do that with TVs watching.
Yeah, I think
we also believed, Mr. Pereira agreeing.
We believed in the process.
Yeah.
It was obviously it wasn't me who sort of just gave the green light to it and said, "Oh, they want to record this." It was based on that chat we had that night. They then went and spoke to the CD and some of the consultants and sort of highlighted some of this, and so they wanted to highlight the work the fantastic work that was being done at the liver unit.
Yeah.
So I think by then we were confident enough in our data and in our knowledge of that this was safe, and as safe as it could be, and we had independent experts working with us on the trial and with various safety checkpoints to make sure that we weren't having problems. So it was very, very safe, considering what we were doing, and it was again just a bit of so it was great for the unit. It was really good publicity for the unit as well.
Yeah. What is your future plans, Mr. Laing? Is it what plans have you got in academia, in surgery? Is TV in there? What plans have you got?
What plans have I got? Well, I'm really happy where I am. I absolutely love Stoke. It's got this amazing draw on you, Stoke. I went there as a medical student, actually as a Manchester medical student. I was at St Andrews University in Scotland, first of all, for my basic science BMed Sci degree, and then down to Manchester for my the clinical part of my course. And I met my wife at university, and she was a year ahead of me because she did medicine straight away and then intercalated, whereas I didn't get into medicine straight off the bat. So we ended up, she got sent to Keele as a Manchester student a year ahead of me, and so when I came down to Manchester, I came to Keele as well, and we were here for 3 years as med students at the old North Staffs Hospital, and then I did my foundation training in Stoke as well, and my core training. So people, when I first worked there and thought, how have I ended up in Stoke-on-Trent? This wasn't part of the plan. People always said to me that, oh, you'll be back, it has a strange draw on you, Stoke, and I always used to sort of take it with a bit of a pinch of salt, but they were absolutely right. And there's nowhere I've worked where I felt more comfortable and more at home. And that's
interesting. Even though you spent however many years in
6 years,
Birmingham.
6 years, yeah. 6 years in Birmingham. And, there's no doubt that Birmingham is an absolutely stellar unit. And there are some fantastic consultants there. But did I ever feel like I really belonged there? I don't know whether I did. I like to think that I was going to end up there, but for whatever reason, it didn't come to fruition. But as soon as I got to Stoke as a locum consultant initially, I just felt completely at home. And I think you realise as you go through your training that there are lots of facets to your consultant career and lots of things that become important. And we've talked already about quality of life and other aspects of life and hobbies and family and friends. When you look at your working life, there'll be people who are look, I did a PhD, okay, and people will maybe refer to me as having an academic interest. My main interest is really clinical surgery, and that's why I got into surgery. I didn't get into surgery to become a researcher, become a prof. It was never on my radar. I got into research at the right time. I'm the sort of person who'll see something through and will make the best of whatever situation I'm in. That's just how I am. And I'll always give everything my all as well. And so do I have aspirations to continue surgical research? Absolutely. I really enjoyed it, but I'm more interested in translational research than I'd say basic science side of things.
Yes. Yeah.
And I'm really interested in sort of clinical trials and patient outcomes and patient quality of life as well. And again, the more I deal with pancreas cancer patients, quality of life is incredibly important, and that doesn't always necessarily equate to having an operation.
Yeah.
So these are the things I'm interested in. The reason I sort of turned away from transplantation and wanted to focus on HPB was really because of my love for minimally invasive surgery. And I have always loved laparoscopic surgery, and now I want to get going on the robot. And things are moving very well in Stoke. They're already probably the biggest centre in the UK for colorectal and gynecology and urology robotics. Yeah. And
it's a large cancer resection centre.
Yeah, and there are moves to increase the number of systems we have so we can get other specialties like thoracics and ourselves onto the robot. So inevitably, if I'd gone down a route of pure transplantation, that would have gone. Unless you're working in Korea or India and you're doing huge numbers of living donor resections robotically, which again is happening, but that again that there was no plan for me to ever go down that route.
Yeah.
So I wanted to focus on elective HPB surgery. I wanted to focus on minimally invasive surgery, and as I say, within your consultant job, a huge part of that is who you're working with and the team that you have around you. And not just your consultant colleagues, although they're obviously hugely important, but the nurses, the specialist nurses, the anaesthetists, and the patients as well. And you'll never work anywhere in the country and meet patients as grateful and as wonderful as people from Staffordshire. They're just the best there are. And they're salt of the earth. They're incredibly hardworking. They are incredibly family focused, and they're incredibly grateful for whatever you can do for them. So, in terms of what's in store, I really want to try and continue to develop things where I am.
Yeah.
There's huge potential to push things forward. I'm there to kind of support my colleagues in the advances they want to make as well. I've never been out there, even as a trainee. I'd hope that peers would say that I've never been out there for myself. And whenever they worked with me in centres, on rotas, that I was always there to help support them as well. And I'm the same really as a consultant. My interest is in the team. Whatever I can do to drive things forward within the department is what I want to achieve. And so, at the moment, in terms of additional roles that I've taken on in the past couple of years, I'm the lead for the faster diagnosis standard in the West Midlands for upper GI cancers. So I'm sort of starting to oversee the MDT process for different centres and how we can get patients through the system quicker and how we can get them a diagnosis or an exclusion of cancer quicker. So that's one thing that I'm focusing on. I'm very passionate about early diagnosis in pancreas cancer.
Yes.
And apart from loving the specialty in terms of it being a surgical specialty and the skills that we have to learn in order to do HPB and the operations that we do and the pathology that we operate on, which is the best out of all surgical specialties, by the way, even plastic. One thing that attracted me was the fact that there are still huge gains to be made. If you look at prostate cancer survival, you look at breast cancer survival, you look at colon cancer survival, the gains have been made. The margins that are left are relatively slim.
Yes.
Pancreas and liver cancers are at the bottom of the pile.
That's true.
And the incidence is only increasing. So not only can we improve the rate of diagnosis and the earlier diagnosis, but we can also hopefully improve neoadjuvant and adjuvant treatments. And improve our 5-year survival rates. And that we can't go any lower than we already are.
Yeah, I know it's not very successful.
So, hopefully in my lifetime, in my career, we will see those improvements. And again, that was what I wanted to really sort of be a part of. And then who knows what happens around the corner.
Exactly. My favourite part of your PhD was actually at the early part, your acknowledgement. You may cringe me reading this, but I do want to read it. It's a note to your family. You said, I have to begin by thanking my amazing wife, Susan. I started out on this journey in 2014, extremely naive and not knowing what a period of research would have in store. What it entailed was 4 years of hard work, being on call virtually all the time, late nights, early mornings, highs, lows, missed or broken sleep, liver offers, and some days away from home. This thesis is as much for you as it is for me, for them. I want to know that when I'm not at home, I'm always thinking of you. To mum and dad, you always taught me to do my best, keep pushing myself, and work hard for what I believe in. Thank you for your unconditional love, advice, and support over the years. Your Twitter bio, Mr. Laing, says you're a consultant HPB surgeon, husband and father. Let's talk about your most important roles. For you, what does it mean to be a husband and a father?
I remember writing that actually at the end of my PhD. I mean, I get emotional at Bake Off and the repair shop. So it's the most important thing, I'm so blessed to have Susan and the kids, and it's a really hard career. It is hard. It's challenging.
Yeah.
For a number of reasons. The training's long. It needs to be long. I'm sure we could fill another 2 hours talking about why training needs to be long and the other issues that are going on at the moment in terms of the training program and things around it. But it needs to be long because it is the patients are challenging. the conditions are challenging and they're difficult to treat, and the stakes are high. We all have adverse outcomes, as much as we'd like to think we don't. And hopefully the vast majority of surgeons take those adverse outcomes, not hard, but, take them to heart.
Mm.
I know I certainly do. And you have to have the support in order to get through those times. Equally, I've got two gorgeous kids, 12 and 8, William and Beatrix, and they have been raised by Suze mainly. And, I like to think I've been around when I can be as well. Yeah. But, she's just been my rock throughout my training. And as I say, she's done it alongside her own career. And has managed challenges along the way that happen in life, and so she's just been amazing, and she knows that. Well, hopefully she knows that how grateful I am for that. I tell her a lot.
Yeah. It was nice to read.
Yeah.
I asked you because I feel I'm a very family person as well, and that's something I think about, that we talked about earlier. It's not a 9-to-5 job, but it's a lifestyle, being a doctor, being a surgeon. Yeah. But I also really love being at home, whether that's watching TV with family or I call it, my sister, she's here, but I call it organised fun. Yeah. So I'm the one who organises the holidays, organise the hikes in the Peak Districts, but I feel I have to do that, because if I don't, medicine will just overcome me. There's always more that you can do. There's always more portfolio. Always more. You never know if you will make it to the next stage. That's why I organise fun, just to make sure it's allocated. This is a family thing. That I'm
and you make the most of the time that you have. And that was one of my real, I suppose that would be my tip for trainee surgeons, is that you have to maximise the downtime and make it valuable, okay, because it's limited. Your downtime is limited, but you should make the most of it. So, for example, if you have an on-call block and you have days off after the on-call, take your days off. I don't want to see trainees, when they're post on-call. I want them to be at home spending those days, because when you're on call, you're doing 13 hours. You got, around the West Midlands, most people are commuting an hour each way. Yeah. For 6 years, I was commuting from Shrewsbury to Birmingham, and it's an hour and a half with traffic each way. And when you come in after a 13, 14-hour shift, what are you going to do? So when you have downtime, utilize it, and spend quality time with your family. And actually, the more you do that, the less your family resent the fact that you sort of not there. They don't necessarily notice. If they know that you're going to have a few days off afterwards and you're going to go and do something and you're going to enjoy yourself and go and then they'll be less worried about. I mean, it'll still take its toll, don't worry, but it will be less of an impact.
Can I ask, how do you go about talking about those expectations with your partner, or let's say if you're trying to find a partner, explain that I'm planning to be a consultant, upper GI surgeon, I'll be very busy. Your wife also is a consultant, ED consultant. How do you go about marrying that? How do you go about having that conversation?
Well, you just have to be very honest with people from the outset. I mean, Susan's always known that I wanted to go into surgery. Initially, it was orthopedics. But in the end, I decided general surgery was more for me. And it becomes clear fairly early on what that's going to entail. When you're an SHO and then you're trying to get your numbers up, and then you're trying to get your number, and you get onto the training number, and then you're getting rotated around hospitals. It becomes clear what it's going to entail, and you just have to be very honest with yourself, and you're honest with your partner, and you have to be empathetic to what they're going through, I think, because it's not easy to try and juggle everything and to support you through what you're doing as well. And you support each other, you know.
Yeah.
And it's just about, I suppose, having the light at the end of the tunnel as well, and of the consultant job and the security that brings, and the slight change in pace in terms of coming off the registrar rota. I mean, it's still busy, undoubtedly, but it is different.
Yes.
You're more in control of your own practice and your own career and your own life, and you do get, you know, you have that degree of organisation, and you can plan it into the future instead of planning 3 or 4 months ahead and then having to rotate hospitals. So all these things make a difference. And just be there for your partner as much as they're there for you, and but just be sort of mindful as well that it's not easy for you, it's not easy for your partner. At times it is challenging, and you just need to roll with it.
Exactly. Could you talk about your scrub cap? I know you haven't brought it today,
yeah.
But I know that your son made it.
Yeah,
He's an interest in art.
Yeah.
Also, I've seen you tweeting about awareness of pancreatic cancer and identifying it at early stages. Could you talk about
absolutely
the essence of it?
So my son William is 12, and he is a very good artist. William had meningitis when he was a baby, and was very sick with meningitis B, and he struggles with certain sort of aspects of his academic work, but has got this incredible gift for drawing and artwork, as well as being a fantastic sportsman and just a brilliant all-round lad.
Mm-hmm.
So he drew me a picture, HBB, anatomical picture, which is in my office, and it's my pride and joy, and my colleagues love it. And essentially, TJ, who's one of my consultant colleagues, was talking about raising awareness for pancreas cancer locally. Yeah. And as you'll know, having worked in Stoke, everyone calls everyone Duck.
Yes.
Hey up me Duck. And he thought that he could maybe, we could maybe make the gallbladder and pancreas and duodenum look like a mallard duck.
Okay.
Gallbladder, the green head of the duck, and the duodenum, the body, and then the pancreas, the sort of wings and tail. So he said, do you think William could maybe work on that and just see what we can do? I said, yeah, I'll ask him. So anyway, that night I went home and I said, well, I've got a project for you. And I showed him a picture of a mallard, and I showed him a picture of a gallbladder and a bile duct, and I said, could you maybe turn that into that? He's like, yeah, I think I can, Dad. So literally within 45 minutes, he'd drawn what is now the pancreas duck. And so as a little gift to TJ, before we actually set up the local awareness campaign, I got them printed on scrub caps for me and my 3 colleagues.
Mr. Athwell,
Mr. Athwell, Mr. Batt, and Mr. Durkin.
Okay then.
And Mr. Durkin was actually my consultant when I was an F2.
Right.
Many moons ago. I won't allude to his age, but
yeah.
he was a new consultant when I was coming through the unit as an SHO. And we now sit in the same office. So yeah, got them made into scrub caps, and now we've now had some posters made and some little trolley key ring things, trolley coins, and some leaflets, and those leaflets are going to go into GP practices around Staffordshire with the symptoms and signs of pancreas cancer, and it might be your pancreas duck.
Okay.
So very, very exciting, and I'm really proud of William's pancreas duck, and he's very proud as well that he's been able to potentially impact upon a bigger issue. Exactly. So
I've seen your cap and the detail of it. I'm sure your son probably has better HPV anatomy knowledge than I do, Mr. Laing. So I want to thank you for your time today. Fantastic. It's been fantastic reading your PhD, also watching the BBC documentary. You've lived a very exciting life, and not only that, the 1 week that I did work with you when you were on call and post take, I really enjoyed it.
Well, it was fantastic having you, actually.
Yes.
It has, and I'm glad you enjoyed yourself. And it's just a shame that you've chosen plastic surgery.
Maybe later, maybe later. But I wish you all the best in your future.
Thanks
Thank
so
you,
much.
Mr. Laing.
Thanks for having me. Cheers.
In closing the podcast, I would like to read Mr. Laing's final remarks of his PhD project. My final thank you is saved for the donors and their families who gave the greatest gift of all, and for the patients who selflessly risked their lives in pursuit of better outcomes for others. Thank you for listening to the Second Opinion podcast. Please like and subscribe if you enjoyed, and check out our other channels. See you next time.